I have until like 7:15. Here.
Error number 4.
Yeah. And again, I will issue an order. But we're still recording.
You consider a name.
But let's discuss that off the record, and then we'll figure out whether that. I understand why you're asking. Just don't know whether it's. That is a question that I was going to ask you guys. So, for you and your clients, how long do you think take you to pull those things together? And I'll ask the same questions. Well,
Take my What you said? Sorry, it's
all right, so we'll say May 4th then, and I'll include that in the order. So now we're going to turn to closing arguments. Since the applicant bears the burden of establishing that the proposal should be granted, I generally give them the last word. So I will start with closing arguments from Gaylord Hospital Council, and then special care. And I apologize, but you are going to have to
use my opera voice.
Okay.
First of all, we want to thank you for the opportunity to speak today. What I'd like to say on behalf of Gaylord is that the focus of determining whether to approve or deny this con application should be on specific needs of the patients in Connecticut and services that already exist to treat patients who need inpatient rehabilitation services. National data does not capture the needs of the patient population on the ground in Connecticut. Encompass uses national data to justify its calculations, number of beds it seeks in its application. It ignores key statistical differences in Connecticut. Encompass also ignores that we don't really know how the Danbury, Waterbury facilities will impact the other options that are available in the state. Just don't know in the long run what that's going to look like. One key problem in Encompass's analysis is that it's a clear lack of understanding of what happens again. Gaylord far exceeds the national data points that Encompass relies on. Gaylord provides all the therapies that Encompass plans to provide, all on its 440-acre campus, just 25 minutes. Hope if OHS takes anything from this hearing today, it is that Gaylord serves so many more patients than the handful of patients who are on ventilators heard about today. In fact, you're generally only about 5 patients at 135 at any given time. You're on ventilators. Everyone else receiving intense therapy sessions and intense rehabilitation services. Gaylord is a vibrant, state-of-the-art facility, has since 1902 provided the very types of therapies and services that Encompass plans to offer, often far exceeding the 3-hour, 5-day-a-week therapy requirements that Encompass has to meet and that they tout, setting its facilities apart, especially among contacts. Compounded by the additional strains on staffing, so much about today, it's clear that the policy plan is not only future, but absolutely will have a negative impact on the state's health system by creating an overcapacity of beds and an undercapacity bed. Simply because Gaylord already provides the same and more services to patients in need of inpatient rehabilitation services. Gaylord requests the application.
I understand. Here we go. So I just wanted to start out by addressing a couple of the questions that the agency had. So at page 14 of Ms. Rudman's testimony is the spending that Connecticut is right now spending across the continuum. Skilled nursing facility, home health agency, and PERF. Okay, so this is national data, but we know in Connecticut that there is a penetration of skilled nursing facilities. That is per episode of care much cheaper than, cost sense than what the IRFs provide, and even more so in the home health setting. So we're talking about quality, we're talking about being third in U.S. World News report. So that's important and relevant. Also, when you go to Ms. Rudman's testimony at page 10, I want to speak to that because there's been a lot put around this idea of discharge, which Encompass does in 12 days. Well, if you're in the hospital industry, you've heard about treat them quicker and discharge them sicker because you spend less on each episode of care if you get them out of bed. It's an episodic, a DRG payment. So what the MedPAC data shows, it is in Ms. Rudman's testimony, there is more discharge to home. There's also, compared to a skilled nursing facility, on IRFs globally, not talking about Encompass, but there are more 30-day readmissions for preventable illness. Okay. I would certainly draw your attention to that. Okay. Then I want to speak to sort of this idea that around the central Connecticut region and the lower River Valley region, there's a wall that because there's no IRF in there, then nobody can travel. We're a small state. You've heard witnesses talk. They're regional, statewide. So remember that these are medical surgical beds in IRUs of these hospitals. They can be flexed anytime they want. Med surg or flex beds. If there's a need, we're going to meet them. So recall that both of these LTACs, if there were a need, would have created, only make common sense business-wise, to create their own IRF units. So this idea that there's not crossover in the patients, there is, but also where's the need? What you have heard, and in Ms. Rudman's testimony is, what does the hospital association say about what's needed? we talked about boarding, OR boarding, huge problem. But the problem, according to CHA, is the long-term medically complex patients. In addition to that, people are reluctant to take Medicaid rates, right? So Medicaid patients are often hard to transfer. Got an applicant over here, $1.25 million EBITDA, billion dollar EBITDA, who is taking 7% Medicaid, when Yale is transferring, as data has shown, 28% Medicaid patients for a few. So the idea here is that there is clearly a demographic shift. The age wave's honest, but this is premature. And now let me just speak to Chafin's need analysis. It's sort of like, that's my story I'm sticking to. But her need analysis is completely different, including in Danbury, there was no 10% migration factor. Where'd that come from? Why here? Was it just raising to show a bed need? There wasn't one in Danbury. As the hearing officer properly pointed out, the Danbury facility, CON, in the proposed final decision was denied. Later, there was a modification reconsideration, and it was approved, but nowhere was the need methodology endorsed. Similarly, Cam Health, just an agreed seller, no discussion of the need methodology. So what we have here is basically Goliath against the Davids, who are the nonprofit safety providers. So when we look at the outcome data in Connecticut, I believe the doctor said, well, we can't know what the outcome data is. Yes, we would. We would know, because the legislature would be hearing about, let's pass some sort of law to up the quality of home health and skilled nursing facilities. We're a small state. We know that.
How hard do you gone over?
Okay, let me just.
We get trapped in.
I understand. I just think what you have to be concerned about is this agency is not in the business of creating jobs and trying to increase municipal tax base. It's about accessibility, it's about quality, and it's about cost. And it is not cost efficient to have a provider that says we're lifting all boats, and that could be owed for overutilization. And we're going to be hurting the providers who do provide substantial Medicaid services. They can afford to do it, but it's a fraction of what the nonprofits. And what about the uninsured? Safety net's got to take them in. Take a look at the charity care policy, the charity care revenues that are attached to that financial worksheet. They're minuscule. So who gets stuck holding the bag with Medicaid patients? It's going to be the nonprofits. Had a bad experience in this state, as you said, with for-profit healthcare. Don't invite it with a application that, as we said in our petition, at best is highly agreed. Thank you.
Thank you. That's it. We want to thank you. I also want to thank the we are asking the quality. Very service area in most. Sense. Heard statements, analysis, methodology. I appreciate the comments or validating. Great. It provides single reference criteria. Question. Is finding the applicant demonstrated that your object by the applicant. That presentation where it addresses the capping there. It's not national. National ban. And continues along the lines of A, as a result, that for the phrase "poop" a lot, but analysis don't through. Very happened with Johnson. Even affecting its analysis without the corrections was in the math corrections was immediate. So my certificate is correctly identified gap in your care. And again, record medication, witnesses, Kavanaugh, there's evidence there. And in response to your question, there was no access to, are there any addresses? They're showing the benefits conditions under discharge to home. Here to see. In addition, and I know Ms. Chafin in other states, when states show when it comes. That good and very we said to see likewise to have a choice have alcohol now we are working today. I'm sure everyone is a family member and wants to be close to wants to noise and as back home. Along with people. That's what this is. Without opinion. And it makes people the application of this. That's voice. That's okay. Isn't there a need to restore the patient's function of this? Attack providers, valuable resources, but understanding services Focus on the need. Your situation. Those reasons.
That's it. Thank you all again for attending today. And a reminder to anyone remotely that written public comment can be submitted up to 7 days from now at concomment@gov. Hearing is hereby adjourned, but the record will open until closed by OHS after receipt of the late files. Very much.